Hello, I'm Dr. Brian Koffman, a retired family doctor and the Chief Medical Officer, Executive Vice President of the nonprofit CLL Society, and I'm a CLL patient myself. And I wanted to start by thanking the Video Journal for inviting me and for iwCLL for the opportunity to present this research. At the CLL Society, we are interested in the patient's perspective. And since the introduction of the tyrosine kinase inhibitors, specifically ibrutinib, there's been a revolution in how CLL was treated. Before their approval, all CLL therapy was fixed duration chemoimmunotherapy. But with the introduction of ibrutinib and others that followed, there was a new paradigm, a paradigm of continuous therapy that was taken until disease progression or intolerance. That shifted again with the introduction of new novel oral agents, which allowed fixed duration to come back as a possibility and allowed patients to have non-chemo approaches that featured a fixed duration combination. The role of MRD, meanwhile, was also evolving. So we wanted to look at how patients felt about these changes and what their comfort, awareness, knowledge, and preferences were related to these. So we took a look at 134 patients and 15 caregivers across 12 different countries in Europe, and we presented at iwCLL the data. The first result that we looked at was what patients knew about their prognostic markers. And what we found, not surprisingly, is that while a significant number of patients knew about their 17p status, as we got to more esoteric markers such as complex karyotype or Notch1, most patients were unaware. Where we focused most of our research on was patients' awareness and familiarity with minimal residual disease. And we found that about 2/3 of patients were aware of their MRD status. And more than half had an understanding, self-reported understanding of what MRD meant in terms of managing their disease, how it was measured, and what it measured. However, when we looked at when MRD should be used clinically, there was a disconnect with this self-reported understanding, with a significant minority of patients wanting testing for measurable residual disease when it was clinically inappropriate, such as at time of diagnosis or before treatment begins, or when routine lab showed persistent CLL. And only about 1/3 wanted the testing done when there was no routine lab evidence of CLL, suggesting a significant learning gap. When we broadened out to take, when we looked at limited duration therapy and what were the benefits for that, the number one benefit for patients was the promise of a continued remission off of therapy, not surprising, followed by it being a period without medication side effects. When we broaden out to take a bigger look at what were the important factors in patients' choice of therapy, ranked most important was the possibility of having future options, a therapy to go to if the therapy they were on failed, suggesting patients get that CLL treatments are usually palliative. Overall survival was a close second. Next came the ability to reach MRD, followed by avoiding chemo, and only then came limited duration. Minimal lab and office visits ranked last. So in conclusion, our study suggests that despite high levels of reported self-confidence in the understanding of MRD, a significant number of patients had preferences for getting MRD testing when it was not clinically indicated. And as the importance of MRD testing grows and finite therapy grows in CLL management, it's going to be incumbent upon providers to provide better understanding and consider their patients' awareness, understanding, and preferences to help them become more informed about the evolving practices in managing their CLL. Thank you very much for letting me talk about this trial.